Thank you very much for the indication to speak. I knew Amber was going to pull out some of my own papers, so I came prepared. So I'm going to try to convince you that based on the efficacy results, POEM is not really the future. POEM is already the present, and we have enough outcomes data to say that it's really the most effective treatment for achalasia that we have in 2021. These are my disclosures. They're not relevant to this topic. So I really like achalasia because I think it's actually pretty simple from a pathophysiologic standpoint. The esophagus loses enteric inhibitory neurons, and this results in two things. When a patient swallows, the lower esophageal sphincter doesn't relax, and the body doesn't peristalse. So all treatments, whether that's medication or myotomy, they work in the same way. They lower standing LES pressure, so that basically the food bolus just falls from the esophagus into the stomach by passive transit. So if you were to design a perfect treatment for achalasia, what would that perfect treatment consist of? Well, it would be safe, there'd be minimum morbidity, easy recovery, pain-free. Of course, be effective. So what does that mean? Well, there'd be symptom palliation via durable disruption of lower esophageal sphincter and improvement, long-standing improvement in esophageal emptying. And then we have to remember that all functional surgery can cause functional side effects. And in the case of myotomy, the main functional side effect would be iatrogenic reflux. But in terms of this debate, I'm going to leave that to Drs. Aoyang and Spear to duke it out. And for this portion of the debate, I'll focus on how do laparoscopic Heller myotomy with partial fundoplication and POEM compare in terms of their safety, postoperative recovery, and most importantly, efficacy. So how about the safety and recovery? There have been a number of comparative studies where Dr. Sheda and I did fellowship, looked at that comparison in Portland, and POEM was better in terms of decreased operative time, less EBL, and lower length of stay. An Italian comparative study across 2 centers with high volumes, same thing, POEM, lower operative times, lower length of stay. North Shore, just north of Chicago, Mike Ujiki's group, looked at the same question, lower length of stay, less pain, intuitive, there are no incisions, and faster return to activities. And then the randomized trial, which was alluded to, it wasn't powered to detect a difference in serious complications, but you can see there's almost a 3-fold higher rate of serious morbidity in Heller than with POEM. So I think we can kind of safely conclude there's a faster recovery, less blood loss, faster OR times, less pain, and the potential maybe for less serious complications. And I think the reason for that is, the most feared complication of myotomy is perforation of the mucosa. And I would argue that POEM is a much more safe and more precise way to do myotomy. You see here with a Heller, you're basically scraping the muscle off the mucosa. There's no separation between the two, and often there can be fibrosis, especially if the patient's had prior endoscopic therapy. It could be very challenging to get all the muscle off. And for the same reason, there can be a potential for a missed muscle fiber. This was a case that I did when I was a resident with Nat Soper as a surgeon. He had done hundreds of myotomies. We thought we were finished. And then we were using an endoflip for one of the first times. We inflated the balloon, and we saw very clearly only after inflating the balloon that there was a band that we had missed. So this is, extremely one of the most experienced surgeons doing this operation in the country, and he would have, we would have left the OR with that band right at the GE junction. POEM, the myotomy is done in a very different way. So first you create a submucosal tunnel with hydro and electrocautery dissection. So basically you're creating this zone of safety separating the muscle from the mucosa before you start the myotomy. And then you can see here the mucosa is completely out of the picture, and you can very precisely, fiber by fiber, divide the muscle, having no fear really of injuring the mucosa once you've made that tunnel. And I talked to my colleague, Eric Hongnes at Northwestern, and between the two of us, it's been over 3 years and well over 100 POEMs since we had a last mucosal injury, and we've never had a missed mucosal injury or any leak after we got out of the OR. I think that's a testament to the procedure, not our skills, because we've definitely had mucosal injuries that we've repaired during Heller's in that same time. So how did the efficacy of the myotomy compare? Obviously the most important thing in a functional operation. There was a recent meta-analysis by Dr. Marco Patti and his group, basically looked at every high-quality case series of Heller's and POEMs that's been published, over 5,000 patients in the Heller arm and almost 2,000 patients in the POEM arm. And overall, all the studies didn't use obviously the same symptom scores or outcome measures, but when they tried to pool them, POEM was more likely to improve dysphagia overall at both 1 year and 2 years. And then the randomized trial, which you talked about, really excellent trial, over 100 patients in each arm. The endoscopists and surgeons were past their learning curves in both procedures. Similar treatment success at 2 years and similar improvement in LES pressure. So I think we can safely say, at least in the short and medium term, that the myotomy is equivalent, or maybe even POEM is superior myotomy, and I would argue it's because of that precision and separating the muscle off the mucosa. And what about the long-term outcomes? Well, I think this really may be Heller's Achilles heel. In the European achalasia trial, so this was the best randomized trial that's compared Heller and pneumatic dilation, there was over 90% success in both arms at 2 years, but that decreased to 84% in the Heller group at 5 years. So basically whatever treatment you look at, but definitely Heller, there's a degradation in success over time. That's undeniable. This Mayo series, really testament to how they follow the patients. The longest follow-up of any Heller myotomy series in the literature. The mean follow-up was 17 years. Some patients were followed out to 40 years. And over time, there was a 47% failure at a mean of 17 years for Heller. So if you follow these patients long enough, a lot of them are going to have symptom recurrences. Now, this is something that I think is a really unanswered research question. Why do the symptoms recur? That's something that's not very well understood, I would say. But we've seen in our practice, I'm lucky enough to work with John Pandolfino and Peter Karillis, two pioneering gastroenterologists, the creators of the Chicago classification at Northwestern. And so they get a lot of referrals of patients who've had Heller myotomies elsewhere and then get referred to us with recurrent symptoms. And I would say it's a little hard to sort out the etiology of the recurrences, of the recurrent symptoms, but there's a very high incidence of hiatal hernia and obstruction due to a problem with the fundoplication. So here's a patient of mine who had a Heller 5 years ago at an outside hospital, and you can see that the GE junction, the LES, is actually wide open. That was confirmed on manometry and flip, but there's a fairly large hiatal hernia and a resulting angulation at the GE junction. So we performed a hiatal hernia repair. We do, in these types of cases, intraoperative flip to measure the distensibility of the GE junction before and after reduction of the hernia, and the LES was wide open. It was really the hernia causing the patient's dysphagia. And I think because Heller involves opening the hiatus, taking down the phrenoesophageal membrane, mobilizing the angle of His and the greater curvature, you're putting a patient at very high risk for hiatal hernia down the road. And I think POEM, may be an answer in that respect. And then how about special cases? So type 3 achalasia, where the patient has spastic contractions of the esophageal body, Heller has fairly poor results in those patients, especially those who have a degree of chest pain as a component of their symptoms. POEM allows for a much more proximal myotomy. So you can see here a POEM I did on a type 3 patient. The clips are basically at the thoracic inlet. It allows you to make a myotomy ablating the entire smooth muscle segment, the spastic segment of the esophagus, something that's not even close to possible via transabdominal approach. There's only been one very small series, basically pooling all of type 3. It's fairly rare, only 10% of achalasia patients, but pooling results across institutions. And although, again, different outcome measures, different hospitals, it did seem like there was a higher initial clinical response to POEM, 98% versus 81% when compared with Heller. So I think there's some evidence and kind of intuitive rationale that POEM would be better for type 3 achalasics. But just to back up, I want to take a broader picture and ask who is the real enemy here in this debate. Dr. Shada, I can pull out my cell phone. We have text messages going back like 5 years where pretty much every week I'm asking her a question about a patient I have, what to do, what she thinks. And Heller I would agree, it is stellar. It's a great operation. Patients do excellent for the most part. So these are our friends. These are not our enemies. The enemy, unfortunately, is currently insurance companies. Now, POEM, you saw that Dr. Potty's meta-analysis. There's half the number of POEM patients that have been studied as Heller patients, even though Heller's been around 10 times as long. So we have robust data, physiologic data, clinical data on thousands of patients. There's been randomized trial comparing POEM to both standard of care, pneumatic dilation, and Heller. And POEM is without a doubt standard of care. There's no definition that you could come up with of standard of care that POEM wouldn't meet. But still, insurance companies are denying it, saying it's experimental, which is quite frankly ridiculous. They're basically, when I talk to them on the phone, I mean, I have to have like something to punch while I talk to them on the phone in my office, but they say, well, I agree with you, doctor, but the last time we updated our policy was 2009, so we can't include these studies. Okay. So in summary, I think, POEM wins. There's equal or better operative safety, that's been shown. Definitely shorter length of stay on average, certainly less pain and a faster recovery and no incisions. And when I lay it out, I do POEM and Heller, I think I lay it out in a pretty even-handed way. I would say about 90 to 95% of patients who qualify for both choose POEM because of those factors. And I think as far as we know and we would expect from the pathophysiologic nature of the procedures, there's equal or even better short and medium-term palliation of symptoms with POEM. And then I think, this is obviously something that is to come that we don't know, but I think because of the lack of hiatal mobilization and closure, there's a potential for better long-term outcomes because there may be less risk of long-term hiatal hernia in these patients. So I would say, I hope you agree with me that the future is actually now and that POEM is the most effective treatment option for most patients with achalasia in 2021. Thank you.